It's all clear to us that patients with non-small cell lung cancer of a non-squamous type, so this is mostly adenocarcinomas, should get testing for EGFR mutations and ALK rearrangements. And that's because those two alterations lend exquisite sensitivity to EGFR inhibitors and ALK inhibitors. I routinely test all my patients also for K-RAS mutations. And that's because K-RAS lends a distinct biology that is not associated with sensitivity to any of those inhibitors, and also means that that tumor is not going to carry some other more rare alteration. If K-RAS has been found in your tumor, stop there, focus on that target. But if no mutations are found, then we dig further. And so routinely at our practice at Dana Farber, we now test for alterations in BRAF, because those patients can get BRAF inhibitors. In ROS1, those patients can get crizotinib. We also test for alterations in PI3 kinase and HER2. Those patients are eligible for clinical trials. And on a case-by-case basis, we are now increasingly testing as part of research studies for other alterations. MET amplification, which is very rare but can be very important when patients have it, and for alterations now in squamous cell carcinoma. So we have a panel of alterations we look for in squamous cell, which includes FGFR amplifications, PI3 kinase amplifications, PI3 kinase mutations, and others on a panel. What's more, in the coming months, maybe 6 months from now, Dana Farber and the Brigham Women's Hospital, and when I say 6 months from now, probably in the summer of 2013, Dana Farber and the Brigham Women's Cancer Center is going to have a Nextgen sequencing panel that we do routinely on lung cancers. And so the cancer gets tested for alterations in 100 different genes, and that can detect small point mutations, insertions, deletions, amplifications, and rearrangements in key genes. That's sort of a one-stop shop where if you have a big enough specimen, you can get all of these genes tested at once. And that's really what we think is the state of the art going forward, and it's going to allow the most flexible and comprehensive testing for our patients. To pull that off, the key is getting an adequate biopsy. And I have no qualms about arranging an additional biopsy for my patients if all that we have available is chemotherapy, but I have an instinct that this person could have some additional alteration in their cancer that deserves digging for. And so sometimes we need to cut out a lymph node or do a needle biopsy of lung tissue to test for these additional alterations and find that mutation that gets you onto a trial that changes your experience of living with lung cancer.